Welcome to another episode of Flash Facts with Ty in 5 minutes. Let's go. Today we'll talk about Diabetes Mellitus Type II. This is one of the most common diseases in the world, particularly because it accounts for a majority of healthcare expenditure in many nations across the globe. Today we'll talk about several things about diabetes. It's important that we know how do we screen for diabetes, who do we screen for diabetes, what are some of the abnormal values, and when we find these abnormal values, how do we intervene? So first question, who do we screen for Diabetes Mellitus Type II? According to guidelines, typically would want to screen patients that have BMI above 25, particularly in all populations, and for Asians we go with 23. If they have that BMI above 25, in addition to a risk factor, we screen that person for Diabetes Mellitus Type II. We also screen every adult older than the age of 45 years. Second question, how do we screen for Diabetes Mellitus Type II? Several ways that we can screen for Diabetes Mellitus Type II. Number one is the hemoglobin A1C. Hemoglobin A1C basically looks at your red blood cells that have, been available for the last 3 months in the blood and basically sees how much of the glucose they carry. Second test, we use the fasted plasma glucose. We also have the oral glucose tolerance test. 2-hour postprandial glucose will also be useful in the screening for diabetes. This particular test, the oral glucose challenge test, is more indicated for pregnant patients. So what are some of the abnormal values that we find in the screening for Diabetes Mellitus Type II? When it comes to hemoglobin A1C, anything from above 6.5% will typically be diagnostic of Diabetes Mellitus Type II. When we're looking at fasting plasma glucose, anything of sugar above 126 milligram per DL will typically be diagnostic of Diabetes Mellitus Type II. When you talk about the oral glucose tolerance test, any glucose of above 200 milligram per DL, 2 hours postprandial, will typically be diagnostic of Diabetes Mellitus Type II. We have a patient who has a random glucose of more than 200 that presents with symptoms of diabetes. That is enough for the diagnosis of diabetes. So what are some of the symptoms that we talk about when we look at Diabetes Mellitus Type II? We think about things like polyuria, polydipsia. Polyuria basically means that they're, peeing a lot. Polydipsia, they're drinking a lot of water. If they're having blurry vision, that might be a sign of diabetic retinopathy. So these are some of the symptoms of long-standing diabetes, and if we have a patient with random glucose of more than 200 with any of these symptoms, we typically would diagnose Diabetes Mellitus Type II. Backtrack for a little bit now and talk about pre-diabetes. Pre-diabetes is basically a state that says you're most likely going to have diabetes, and we have to be able to catch patients at this point and be able to prevent them from getting diabetes. So what are some of the abnormal values that are diagnostic for pre-diabetes? We typically want to look at hemoglobin A1C between 5.7 to 6.4 is mostly diagnostic of pre-diabetes. And when it comes to the fasting plasma glucose, anywhere between 100 to 125 is mostly indicative of pre-diabetes. When we look at the oral glucose tolerance test, the 2-hour postprandial glucose, we look at glucose values in the serum of between 140 to 199. These are some of the values that are more indicative of pre-diabetes. So how do we interpret these tests for diabetes generally? When we look at the 3 tests that we mentioned, hemoglobin A1C, the fasting plasma glucose, and the oral glucose tolerance test, we need to have 2 abnormal tests that are done consecutively to be able to make a diagnosis of Diabetes Mellitus Type II. But what if we have one abnormal test? If we have one abnormal test, we have to repeat that abnormal test to be able to make a diagnosis of Diabetes Mellitus Type II. So we have these abnormal tests. What are some of the things that we'll do initially to prevent complications of diabetes? We have to treat diabetes according to a goal. The goal for the HbA1c typically is usually less than 7. There's several guidelines that says, what the goal should be, but most people's general consensus will be hemoglobin A1c of less than 7. Again, if we're dealing with a patient who has pre-diabetes or a patient who has been newly diagnosed with Diabetes Mellitus Type II, the actual disease, we typically will want to start from lifestyle modifications. Obviously, diet, exercise. Why is exercise important? Exercise is important because when you exercise, you allow for the transport of glucose into the fat cells and the muscle cells, not necessarily dependent on insulin. So what we call this is the insulin independent glucose transport into the adipocytes and muscle cells, typically through the glucose transporter 4. Try the lifestyle modification, diet and exercise. If that doesn't work, then we'll start to consider the oral hypoglycemic agent. What are some of the oral hypoglycemic agents that we use? The number one gold standard is metformin. Metformin more so because of the cost. It's readily available. We know that it works very well for Diabetes Mellitus Type II. Even in patients that have pre-diabetes and metformin, after we've tried lifestyle modifications, diet and exercise, and that doesn't work, metformin will be, a good place to start for whether it's pre-diabetes or diabetes, the actual disease. So when we start with metformin, again, we're treating these patients towards goal. If we're not able to achieve the goal with metformin, we basically up-titrate the doses of metformin, and after that, we might be able to add some of the other oral hypoglycemic agents. We have a vast array of hypoglycemic agents to add to metformin. Typically, in the past, we'll do things like sulfonylurea, but we're very well aware of the fact that sulfonylureas will cause hypoglycemia. They have a higher incidence of causing hypoglycemia. So basically what they do is, they hit the pancreas. If the pancreas are still functioning, they block the transporters in the pancreas and allow insulin to be secreted from the pancreas. And if insulin is in the blood, obviously the risk of hypoglycemia is higher. But nowadays we have so many other oral hypoglycemic agents like the DPP-4 inhibitors, the GLP-1 analogs, the SGLT2 inhibitors. The DPP-4 inhibitors and the GLP-1 analogs are basically trying to mimic the endogenous incretins. Incretins are hormones within the body that typically would facilitate the production of insulin when we eat. So the good thing about these drugs is they only work in response to consumption of glucose. When the food goes into the intestine, stimulates several messengers that allows these incretins to get the signal and basically they cause insulin to come into the blood and take the sugar from the blood. So the risk of hypoglycemia in these instances are much, much lower compared to things like sulfonylurea. SGLT2 is a very exciting drug that is now very commonly used. The mechanism basically goes to the proximal convoluted tubes in the kidneys and blocks a transporter that allows glucose reabsorption. So basically it causes glucose to be lost through the urine. One of the amazing things about this drug, why I said it was exciting, is because of the cardiovascular mortality benefits. It's not the only one that has been shown to have cardiovascular mortality benefits, but it's particularly one of the only oral hypoglycemic agents that has that. GLP-1 analogs have also been shown to have, cardiovascular mortality benefits, but particularly those ones, a lot of them are injectable. So again, remember what I said with the management of diabetes mellitus type 2, you're trying to treat towards a goal. The reason why you're trying to treat towards that goal is because you can avoid the complications of diabetes mellitus type 2. So next thing, so what happens when oral hypoglycemic agents don't work? Meaning we're probably on about 3 oral hypoglycemic agents for diabetes mellitus type 2 and we're not able to achieve that goal of, hemoglobin A1C around 7 or less than 7, we now have to start to think about using insulin. So how do we think about using exogenous insulin?